cataract side and a refractive kind of cosmetic side. And it's on my cosmetic side that I want to kind of focus on how I've been using this product for close to 10 years now. So I think in terms of the big picture, it is a very simple tool to use. We're using it with intelligence, artificial intelligence software, and basically what that's doing is helping us dovetail different types of treatment profiles for each individual patient. So my practice has 500 physicians that refer into it. So by the time I'm seeing a patient, they've already been touched probably 7 times in some way, shape, or form. What we want to do is we want to spend time discussing this with our patients, but we all know whether it's an acute patient, so let's say we're talking about somebody that's like a cataract patient. They come in, you say, listen, Ms. Johnson, I want to do your cataract surgery. These are your choices in the US. You can do something that insurance pays for or something that insurance does not pay for. And the insurance not paid for is going to get you out of glasses more. So we're going to go ahead and schedule your surgery today, but we're going to intervene because you have dry eye issues. And most of them say, yeah, doc, I already know that. But we're still going to go schedule your surgery. We're just going to have to come back and repeat some of the measurements. And many of us are doing this, I see on the wall as well, that we will treat them once or twice while we're waiting for surgery. So typically for me, with cataract surgery, it's probably about 4 weeks. So if you come see me the 1st of September, you're probably going to be getting your cataract surgery at the 1st of October. We do them about a week apart. For refractive surgery, it's a little bit quicker, but we will slow that down if needed. So we all know what dry eye disease is. Maybe, maybe not. So what the artificial intelligence is doing for me is helping me with all these co-conspirators. And the co-conspirators may be a drug, it may be an immune system problem, it may be a complication with multiple medications that you're having. So what I really think that when you're thinking outside this box, although my artificial intelligence covers 9 buckets, okay, it's not just like aqueous deficient or evaporative deficient or a mixture. We now have 9 buckets, and the artificial intelligence is teaching us the treatment type, okay, and the severity models as well. So how severe is the person, and what we're doing is that really fixing them. So I can show them numbers that said, okay, we instituted LLLT or photobiomodulation, and look, you went from this to this on a variety of scales. Many of it's signs and some of it's symptoms. So we've published most of this, but I don't want to miss the kids. The kids are important too. So we have kids in the US that are working on tablets and screens, and this is from Priya Gupta's article a few years back. We were at a pool at the W, Bill Trattler and I, like, look around, what do you see? He said, I don't know, I see a bunch of people in a pool. I said, who don't you see in the pool? And the people that weren't in the pool were all the kids, and they were all looking at what? Their tablets and playing on their phones. So I think that the kid population is very approachable with the LLLT. So I'm a consultant to Sponsione, I'm a consultant to these guys, but where I think we're missing is that tip of the iceberg is what we see, but what we don't see is what this machine learning model can do. And I have a poster, so if you'd like to go do more of a deep dive, I presented a poster here on this topic as well. Now, how do I know that you call a 1 is what I call a 1, or what she calls a moderate is what I call a moderate? We have all these different patterns from the actual articles that were written. So she's going to call a grade 1, and you're going to count dots just like I'm going to count dots, and we have shown that it works extremely well in terms of functionality. So a lot of this is being done by who? Not me, I don't have time. My technicians do most of this. And then the other beauty is the symptoms part of it. The patient answers before they even get through the door. So the lion's share is called CDERS. It's a clinical evaluation. We include speed and OSDI. There's a couple other things if you use those testing too, you can add to it. But this is what we're showing in terms of the type model and the severity model. So our area under the curves are very respectable. We only have about 30,000 data points. You say, well, that sounds like a lot. Well, you need about 150,000 data points. We now have 500 physicians that are adding to the software, and we're just going to get better and better as we go. So what's the machine model going to do? And we published that as well. But the machine model is going to help us guide those patients in 2 factors. One is what we're doing actually working. 2 is the patient actually doing what we're asking them to do. So that's the biggest thing. Compliance in glaucoma, compliance in dry eye is huge. I had a lady that came into my office the other day, and I said, we're going to do this, we're going to do that, we're going to do that. She goes, no. And I said, I'm sorry, what? And she goes, I'm not doing any of that. And I looked at her, I was having a bad day, and I said, you know, I'm so sorry. I have wasted your time. Chelsea is my technician. I said, Chelsea, please don't charge this lady. She's had to wait here for me for about 20 minutes. I appreciate you coming in today. It was a pleasure meeting you. Left the room. And she looks at Chelsea and she's like, he is going to come back, right? And she goes, I don't think so. I've never seen him do this before. So if you get that challenging patient, my staff, they get hammered by these people. So they've got to do what you ask them to do, or it's just a futile concept. They're going to spend money, they're going to get angry, and it's just not worth it. You've got to be on the same page with the patients. So the pharmaceuticals, you just have this plethora of stuff. We have all those in the AI software. So all of that, LLLT, IPL, all of those things are suggestive. And like the Vive is new and Extembi is new. You guys had Evo Tears, it's Mibo Tears now in the US. We've got new different improved models like Tyrvaya. So I like to categorize those in 3 different buckets. Number 1 is your acute. That could be a steroid. That could be Tyrvaya or something of that nature. You have your chronic, okay, which is like a Cequa or a Vivi or some of that type of nature, Xiidra, Lifitegrast, or last but not least, you have your as needed. Now some people use Tyrvaya as a PRN. Some people use an artificial tear like Mibo or Sustain or Refresh. But I think for the most part, this is my number 1, I said this last year, this is my number 1 thing, like $90 US on Amazon. The one I use is from Aroma Season. It is a heated eye mask, plugs into a computer, plugs into the wall. The patients love it, they put it on. It doesn't do the same thing as LLLT or photobiomodulation, but it's a great accentuation to that. We all know what the tear film does. We all know whether it's a contact lens patient, whether it's a refractive patient in terms of cataract surgery, or whether, and I consider cataract surgery refractive, or whether it's LASIK or SMILE or PRK. We all know the numbers for OSDI. I still use OSDI. I like it in speed, but it's now in the software. I send you an email or a text. You answer all the questions. It comes back to me on my phone and says, you are a X, Y, or Z, and so then I know what to tell my staff member when they're coming in and they're already scheduled for their appointment. I still use the OPD. I'm a consultant to them. I like the rings. I also like Damian Gattinell. I was just with him a few seconds ago. And I love the rings because I can show the irregularity to the patient. I can show them a point spread function. I can show them an eye chart or what it's like to drive in the dark and say, well, this is what's related to the cataract, but I can exclude that and I can say, this is what's related to your cornea. And see where the rings are all messed up? That's why we may or may not want to use a premium channel intraocular lens, but let's try and treat your dry eye and then we'll move them over, usually first to LLLT. The point spread functions, you look at me and go, well, why would I use that? Because I tell patients, I said, go out and look and see what you got on a dark night. Or just shut one eye and look at my light in the room, like, oh yeah, I can see what you're talking about now. And what I want them to know is some of that may be corneal related before I put my intraocular lens in, and what I want them to know is that may be dry related, and that's why I'm making you go through this. But we have all these different ways in which to look at it, whether it's an eye chart or not. You do not have to go spend a lot of money on diagnostics, okay? That's what everybody does. Okay, what should I go buy? What should I go get? That's the beauty of the software. You can use fluorescein, little cost. You can use lissamine green, Schirmers. You can use tear breakup times. Use whatever you have and put that in, but you don't have to go buy a new machine. What I'd rather you do is spending money on IPL, LLLT, maybe a Blafax or something like that, because that's what's going to give you a return on your investment in terms of what you're trying to do is make these patients see better. I know this is probably the most controversial one in terms of can you and I do it the same? Trattler uses a stopwatch. I'm like 1 Mississippi, 2 Mississippi, 3 Mississippi. I mean, you've got now diagnostics that actually tell you a tear breakup time. So I think we're getting better, but I think as long as you're consistent between you and your technician, I think that's the most important part. Now, I like to separate blepharitis or meibomian gland disease, external or internal, however you were taught in residency, because the treatments are different, right? So with XDEMVY now, we have to get rid of the collarettes. Well, I have many of my patients look at me and go, you know, I've been seeing you for like 3 or 4 years and you never told me about these little things on my eyelashes. Why didn't you talk to me about those? Well, we kind of did. We just didn't really have a good treatment for them. We talked about doing lid scrubs. We did BlephX. For those of you that don't know what BlephX, it's like cleaning your teeth. You know, you get your teeth cleaned, even though you scrub them every day, every 6 months. We do BlephX, which is like a big toothbrush in terms of cleaning. Eyelight for me has been huge. So I did the original US trials myself, and I think that this is something that makes patients feel better. And this is one of the original machines. This is actually Morena and Rudy's daughter. So it's a really, really old slide. The mask is different, and I put the mask out there just because in the old days, all the influencers and stuff would take pictures and put it online and do all. So I let the family see what they're doing. This is obviously the IPL. The beauty of the IPL is it's no gel, right? So you don't have to put all that stuff all over their face. And the beauty of it is you've got to be careful of one thing, and that's this, okay? I have never done it. I've never had a technician do it. I am very stringent with IPL about wearing safety protection. I let my technicians do IPL, especially this one, because it's so slick and quick. And they're always about, before they push that button, Miss Johnson, make sure you got your eyes closed. Miss Johnson, you got your eyes closed. Miss Johnson, you got your eye closed. And you don't have to worry about putting all that stuff on. And I really don't even use anesthesia with them because it's so slick and quick. Most people say maybe it's like a little bit of a rubber band or something. But you can get an iris with one shot. And I've got about 4 from other physicians in my clinic, and it's no fun. The light modulation used to be a full mask. Rudy came up with a better idea, the half mask. The patients don't get maybe claustrophobic in it. We still have full mask, whether that's blue or whether that's yellow. I do use the blue and the yellow as well. So the blues I'm using more for my rosacea style patients. The yellows I'm using more for my cosmetic patients or somebody I may put Botox in and they get a little bruise or something from that. So the CSI dry eye diagnostics leads me into all this other stuff that helps me help the patient better. If there's something you don't have, it's okay, but you can do simple things like squeeze. I use Speedway. I've been using Speedway forever. I can get expressors for like $50, and then I basically go from 0 to 4. So either you can express them or you can't, or somewhere in between it's a turbid oil or it's actually paste. And you're welcome to my talk. So if you have a stick, I'm happy to give it to you. Enhancements. So when we first did the original study of 370, I came back at 16.5%. Now I have a real low threshold. I probably maybe a little bit higher than that. Not that they need it, it's just that the patients like it and like how they feel. So I don't know if you guys, I'm one of those guys that like to have my teeth clean. Probably do it more than I'm supposed to or have to, but it just makes my teeth feel better. It's the same way with this treatment. We went ahead with 3 other sites just to make sure. We had 4 sites. We've shown with the mask that the combined low-level light therapy and IPL works, okay? It works very well in a lot of different parameters. And I think this new buzzword of photobiomodulation is now out there in the real world in the literature. But what we still don't have is what's it do? So it's really working on the mitochondrial DNA and in the mitochondria, and it's basically working on that powerhouse. And I always explain it to patients as it's kind of heating from the inside out, okay? The mask that I'm asking you to buy from Amazon, that's heating from the outside in. This is doing something completely different from the inside out, and I completely believe that. And Dr. Polt has shown that. So he's looked at IPL versus LLT or IPL alone or versus LLLT or combinations, and the LLT does a lot more. And I think the big thing about it in this day of COVID or infection or whatever you want to say, it's easy to clean. We just wipe them with these little Clorox wipes. We let them sit for about a minute, and then we can use it on the next patient. We have you guys still have the little, just don't see it. We have a tiny unit and a big one, right? So the tiny unit is our more mobile unit. Our big unit is our workhorse, so to speak. Okay, there, sorry. So our workhorse sits on our cosmetic side. Our tiny unit is really simple and easy to push through. This was developed by NASA a long, long time ago. So I think in terms of LLLT, it's not a new thing, right? It's been around for quite some time, but it's kind of a newer thing, 10 years for us, with us getting into mainstream in terms of ophthalmology and use. The FDA has been a bit of a challenge, and it's not about the data. Data's been solid, it's just about red light. They're real freaked out about red light, and why? Because we're now using red light for myopia management. There's some illicit, as I would say, machines that are actually not doing well for myopia management and other things. They're too strong and they're causing harmful effects. We kind of got dovetail, I think, into that. We then started thinking, okay, how do we just tailor it to a patient? And so we started doing LLLT alone. This was published years ago, and we basically did LLT, waited 2 days, LLT, waited 2 days, because we want to get a person done quickly, let's say. So like a LASIK patient. As long as it's okay with them, Moraine and Rudy used to always kind of explain, it's like recharging your battery on your cell phone or your car. It's better to charge it 80%. It's not as hard on your car battery. But here we kind of need an effect, wait about 48 hours, get an effect, wait about 48 hours. And I do express everybody. Now, we were talking about this last night with one of the pediatric ophthalmologists. Chalazion just go away. I probably in the last, maybe, and I see a ton, probably maybe 1 or 2 a year I have to incise and drain. So I want you in as fast as you can. Even if I'm not there, the optometrist or the other physicians know, just send them over to Karl and we'll get them treated. This is one of the worst little ladies I've seen. She had multiple eyes. They were all over the place. That's after one treatment. She ended up with 2 more, okay? In the article, I say, and if you just put Stonecipher LLLT, these articles will come up. But in the article, I say, you need to wait a month. I just didn't know what the heck I was doing. I wait about 48 hours in these patient populations too. Now, in those that I have to incise and drain, what usually happens is somebody's waited forever to come in, the patient, or somebody's waited forever to refer it, the doctor, and it'll help it come to a head quicker. So these are just some of the differences between what's out on the market and what you get in terms of this product. I think the biggest thing for me in terms of this product is much more multifaceted, and it's gonna let me do a lot more in terms of people in my clinic and treating those patients in my clinic and getting where I want to be. And I don't have to use the gel. The gel is a huge thing for me. Johan, I'll give all this to you. So we were part of the prospective IOL study or phaco study, and so we were assessing cataract surgery. You're gonna laugh, but you see some pretty big names on that, okay? It took us 3.5 years to get that published because nobody believed the results. Nobody said, oh, you know, all those guys are paid, and but it's real. And I think that if you just use one stain and tear breakup time, it's an easy way to avoid the complications. And I think it helps you identify these problem patients, you know, by asking the right questions. But this artificial intelligence software makes it so much nicer in terms of the big picture because it helps us figure out what we're missing. You know, how common is blepharitis in our clinic? How common are Demodex, you know, in our clinic? And they're very common. This is from a friend of mine, Jody Luck's paper. The Demodex is about 56% of your surgical patient population will have 10 or more collarettes, and I think that's important. Tear breakup times less than 7 seconds, which is my cutoff, of 61%. The phaco study, over 50% of central corneal staining in your normal population. And I think in terms of how do these people complain, a lot of them don't complain. It's because they don't feel it. So I think checking corneal sensation is really important because a lot of these patients have gotten older, their eyes are numb, and they don't even feel their dry eye. So in this study, the average tear breakup time was less than 5. in 2 out of 3 patients. Now, if you came to this study, this phaco study, and you said, I got a dry eye, you're out. You were not included. That included 20% of the population. So 1 in 5 will come to your clinic with a diagnosis of dry eye. None of these patients had a dry eye diagnosis beforehand. But central corneal staining is a big deal if what? You're trying to use one of these new fancy-dancy premium IOLs. And I see it all the time. I never use Schirmers. I'm not a big Schirmers fan unless I'm doing a study. It hurts, the patients don't like it. I do it with LASIK. So if I think somebody's on the borderline, I will do a Schirmers, I will mark it, and I'll put it in the chart. So I'll put it somewhere just to say we had that discussion about dry eye from a legal standpoint. So when we look at the category, now this is just cataract. Just remember, if you're not making 1 in 5 of your patients some sort of a dry eye, you're probably missing it. And I'm talking about everybody's practice. I think that's probably for me in my refractive practice about 1 in 3, because my optometrists, many who I've referred patients to them and them patients to me, family members, will say, hey Karl, if they're in a contact lens and they're happy, I'm not gonna refer them to you. That's my bread and butter. But boy, if they ever get unhappy, they're coming over to see you. But I'm like, please, please, please treat their dry eye first. So intraocular lens calculations are huge, and we're trying to do everything we can so that we don't put the wrong patient, a wrong lens in the wrong patient, or the wrong power in the correct patient. They're both bad, they're both a problem, but I just presented an ASCRS that looking at 3,710 cases, my enhancement rate is 1.08%. I'm gonna say that again, 1.08%, that's what the year follow-up. So we're getting these things right. Many of the patients I have, because I've done 83,000 laser vision corrections, are previous refractive surgery patients, and they're even harder to get it right. So I use all the formulas, and in addition to using all the formulas, I treat their ocular surface aggressively. So this is what it looks like. Amanda said, you're not paying me enough to make me do this. And I'm like, Amanda, it's not that bad. So this is one of my staff. It was really hard to find a staff member that had normal meibum. I went through like 6 before I could get a good picture of someone that I could express, and all that came out was clear oil. And I think that says a lot because my staff members average about 26 to 27 years old. So this is my 90-second workup. So this is my bullet point. This is one of my things that I preach and teach, is all you gotta do is pick one. Pick OSDI, pick speed, pick whatever you want to. If you don't want to do fancy software. Use fluorescein for tear breakup time and staining. Use lissamine green for conjunctival staining. And then put that in your chart. And I don't do that. My technicians do that for me beforehand. And so what we now call this is kind of perfect vision. And I'm going to go through some examples. So this is a 78-year-old female with a 45-year history of Sjogren's syndrome. Danny Jones, by the time she was 30, had already punctally occluded all 4 of her puncta. She couldn't cry. So if you look at her and she's at a wedding, she can't cry. And how do I know? Because she's my mother-in-law. And so you say, you're stupid. Are you gonna really operate on your mother-in-law? And I didn't want anybody else to, she's a totally lovely lady. I just knew it was just gonna be a huge challenge of getting everything straight. Did I put a premium intraocular lens in my mother-in-law? Heck no, I didn't. I did a monofocal pus, and I'm okay with glasses. She doesn't wear glasses, except sometimes because I just defocused her about 3/4 of the diopter. She didn't like more than that. But we went through all of this, every bit of this beforehand, just so we could do what? Is get her happy. I do LLLT first, and then I go and wait a bit, okay? So in these complex patients, I'll do LLT that day. So you come in, you see me, I do LLT. I'm gonna say, you're gonna go now see Jenny. Jenny's gonna schedule your surgery, and then we're gonna have you come back in 2 weeks. So we'll institute some sort of therapy, depending on what they need, whether it's meibomian gland disease or whatever. But remember, who's done all this before I even walk in? My technician. So we have the software, my technicians talk to them, gone through all those plethora of things. We use a ton of animated videos. They can be from Johan, they can be from Bill Trattler, they can be from whoever you want. They don't have to be you, but I make up a lot of my own videos so patients can see me. So when they see the video, a lot of times they walk in and they feel like they know me already because they've seen me on a video here, there, everywhere. So what I'm trying to say is the least thing is do, a 90-second workup. Look for it. Measure corneal sensation, because I think that's important, and then treat the dry disease, whether that's before your refractive patients or whether that's before your cataract patients. I let the technician do all of this before I even walk in the room. So realistically, when I'm walking in the room, I'm looking at the patient and I say, look, Mr. Smith, you're not going to make a $6,000 decision in 5 minutes. So we're going to give you, we have a little QR code, we hand them. It has all the videos that we want them to watch about cataract or refractive surgery or ICL on it. They take that home and on the back it says what we recommend. So a standard, maybe like a Rayner EMV or an Aspire Invista, or maybe it's a Vivity or something like a Synergy Toric. So whatever we think, because the patient comes to you for what? They want a recommendation. They're coming to you saying, okay, what would you put it in my eye if I were your brother, or I were your mother, or I were your sister? And that's kind of how we approach it. But at the same time, when you get it wrong, don't miss an epiretinal membrane, so everybody gets an OCT. You're going to miss the mark every now and then, so we're going to touch them up with PRK. In my hands, I use transepithelial PRK 1.08% of the time because it's usually a little bit myopic. If it's hyperopic or hyperopic astigmatic, I use a flap, so I do it under a LASIK flap. But if you miss dry eyes, the patient's like, man, I paid you $6,000 and I still can't see. So I think that you've got to teach them what they have before you start and then stay with them until the end. So I'm going to quit there. Does anybody have any questions?